Welcome to the Dermalorian podcast from the Dermatology Education Foundation. The Dermalorian podcast is made possible with support from Vitama, Tapinarof Cream 1%. To learn more about Vitama, please visit www.vitamahcp.com. That's VTAMAHCP.com. Dermatology NPs and PAs and dermatologists often encounter a disconnect in the clinic when patients with moderate to severe atopic dermatitis are desperate for clearance but skeptical of recommended treatments. In this episode, a panel of DEF faculty members, including nurse practitioner Joe Gorelick, dermatologist Dr. April Armstrong, and dermatology physician assistants Kara Gooding and Darren West, discuss their approach to treatment selection and patient education. The conversation kicks off with Dr. Armstrong.
I think that when I think about my AD patients and think about when do we transition from topical to systemic agents, I think there are several different factors. One is patient readiness. That's important because you may have patients who may not, you think they're the perfect patient for systemic agents, but they are not willing for one reason or another. So, but let's say that that's not an issue. Usually what I do is I look at a number of different factors. Number one is to look at their disease severity, of course. So not only what their skin looks like, but in addition to that, how it impacts their quality of life. And that's really important. So I ask about itch. And oftentimes I do use the scale. I say on the scale of 0 to 10, 0 being no itch, 10 being the worst itch ever. And where are you on average? And when they give me that number, it actually gives me a sense of their itch level. It doesn't have to be a multi-question itch score, itch sort of a patient-reported outcome measure, but even just a simple question will give you a lot of clues. And also, I ask them, what are other ways that you found that your eczema is affecting your life? And then that's a kind of open-ended question that allows them to tell you about that. So usually I really take into account their quality of life in addition to what their skin looks like. Now, I am probably one who is very willing to start a systemic medication, and so if I feel that it has a significant impact on their quality of life, it is something that I think about and then think how they may fall into the moderate to severe category. Now, the payers, again, they may have other criteria. So you need to be aware of that. So when you're filling out or documentation-wise, often payers, their AI system is reading, if you initially starting a patient on a systemic medication, they're reading for body surface area of 10% or greater. If you put an easy score, it will be 16 or greater, and they're reading the word moderate or severe. And for some of our agents, you also need to document failure of prior therapy, so failure of systemic therapy. So to get access to this, there's a technical component to making sure those elements are in the note, because we don't want to redo our documentation or have it kick back and so forth. So those are the parameters I am aware of. In the clinic, when I'm having the patient right in front of me, though, I would say the conversation is really about not only their disease severity, but their quality of life as well. So I think this slide is showing that the itch scale that we talked about and whether they're open to any other modalities, oral pills or injectables. Now, a few things I want to talk about is some patients just don't want systemic medications, and and I see that not infrequently. They read about a lot of things. You're only in front of them for 10 minutes, right? They've been reading for hours and days about different medications possibly coming to you. So they may have certain preconceived notions about what these therapies are, what are the adverse effects, and what are the efficacy. So what I usually in the patient, I think is truly should be thinking about this is say, this day and age, the standard of treatment. This is our standard, is to do this. I understand you have these concerns. Tell me about that. And I hear them out, because if you start a patient who is not ready, you can do all the work. And I've been there. You do all the work, and then they come back the next time. They're like, I changed my mind, right? You're like, oh, darn it. We just spent all that time, and it's time not recuperated. So I actually want to make sure that they are ready as well. So if I see a patient who is appropriate and they are resistant, I say, this is a standard of therapy. I hear their concerns. I say, I understand you may read this. Let me share with you what I know on this. And then I say, let me see you in a month, and let's revisit this. I want you to kind of think about it. So my job goes from prescribing at that visit for this patient who is not ready, to sowing the seed. Your job is to plant the seed, and the main job is actually make sure that they trust you. Because if they don't trust you and they feel like you're just a pill pusher or a injection pusher, they will actually pull back. And then you just lost a patient who could have benefited tremendously from this therapy. So if I see resistance, it's really about establishing that rapport and telling them there are other options. And then we can always go there later, and also I do articulate that it is the standard of care, and we can visit it. So those are my thoughts on the issue.
Other panelists weigh in on this question in a moment, after this episode's Dermalorian Derm Decoder. DEF faculty member Dr. David Cotter addresses the potential role for gene expression profiling for melanoma.
When it really comes down to it, we should be utilizing whatever technology is available to give our patients the best care possible. So my pitch for using GEP in your practice is, you did the biopsy because you didn't know what it was. The pathologist maybe did a special stain because they didn't know what it was. And now you've got a diagnosis of melanoma. And you've got a gestalt of whether that's going to behave, more likely to be good or more likely to be bad. But we don't know for certain. So we should access all information that's available for your patient. And some of that information is available only at the molecular level. And we can access it through gene expression profiling. There's no reason not to do it. I consider it an extension of my biopsy. I want to know everything there is to know about my patient's melanoma when I'm taking care of them.
You're listening to the Dermalorian podcast, made possible with support from Vitama, Tapinarof Cream 1%. To learn more about Vitama, please visit www.vitamahcp.com. Now, let's get back to our panel discussion on atopic dermatitis, as dermatology PA Darren West describes his approach to educating patients about treatment options.
First I frame this properly. My patients don't always know it's an inside-out problem, right? You have to kind of let them know this is not something that you can just always put cream on and get the benefit. So you have to frame it properly. You don't want to just explain, no, we're going to give you some systemic stuff now. We're going to give you some internal things, and we're going to give you injections and orals, and we need to monitor this and that. You have to frame it. You need to set the stage. And that's what, as providers and even medical assistants, you guys can do this kind of stuff. You can kind of get that, answer questions. But I just want my patients to understand why we give them these products, why we're going to that level and extent. And it's huge for our patients to understand the course of their treatment and the outcomes and the long-term course of why we're doing it and the chronicity of this disease. It just makes sense. And so explain that, and then it's a lot easier for our patients to grasp it and understand why we're doing this for them.
Kara?
Yeah, I think one thing you made a great point about is that even those patients oftentimes may be suffering miserably when they're in the office. It is sometimes a big jump for them to go onto a systemic therapy. And it's like you said, a lot of work for us as well. So I think I love what you said of sometimes it's just that first visit of really planting the seed of what you want to do and maybe saying, hey, there's some different options out here. And we know all of our patients are online looking at the information. Probably the second you walk out the room to even talk to your MA, they're already looking up what you told them. So I think that visit saying hey, here's a couple different options. Here's, maybe you give them one or two different things to say, go home and do a little research and then, come back and we're going to talk about this next time. I think that's really helpful. I think the other thing too, when we're looking at quality of life, is sleep. I think that's one of the things that's so important when you ask them, are you waking up from your sleep at night? Because to me, that's automatically like, okay, you're miserable regardless. So I think that is just one other thing to ask. But otherwise, your answer was comprehensive.
Yeah, I don't think you can ever underestimate the psychological and burdensome disease of atopic. And like Dr. Armstrong said, I asked my patients, how often in a day do you think about your disease? How much does this consume your everyday thoughts? If someone's going to say, oh, I think about it once in a while, every few days or every couple of weeks, then it's probably not super duper severe. But if they think about this every single day and they're processing this, it is a severe disease for them. And we have to consider that as a significant reason to start doing systemics.
Yeah, I think it's so important, right? We're busy, we're racing from room to room. You walk into one of these rooms and you know you're going to have that discussion. You got to take a deep breath, go in, you know your job. You got to flip the mental switch for the patient. They have to understand that it's a systemic inflammatory disease causing these symptoms they've been suffering with, and then understand in an empathetic way. These patients have become used to being miserable, and they don't know what it's like not to have the disease. And it's inconceivable to them to think that they can lay down at night, turn off the iPad and all the stuff, and then the itch doesn't become paramount. And so that's establishing the trust with them. And then you have a plan moving forward, whether you do shared decision making and give them a couple things to read, which I would never do. You have to choose for them. But you give them information to read and they come back and they're oftentimes going to be very much more receptive. So let's say you choose an agent to help control their disease care. How do you describe to the patient, and this can go for the JAK inhibitors as well, how do you describe the mechanism of action for biologics and small molecules to the patient in the clinic in that short period of time?
So I think the first thing that I reassure them is that these agents are not immunosuppressive agents, because they're used to hearing the commercials on TV. They automatically think that these are things that are going to cause cancer. And so you reassure them, say, this is not like a steroid where it's going to wipe out your immune system. This is something that is a very targeted agent that's going to, I like to say, tweak a very small part of your immune system. So, and I'll say whether it's for atopic dermatitis or psoriasis, this is, if we're going to use a particular agent, I'll say, this IL-13 is driving your disease and we're going to tweak just that very small part of your immune system. So we're not wiping out your immune system. I think that oftentimes is very reassuring to the patient.
Kara said that it's not an immunosuppressant because they have certain words. So the words we use is important. And the way that I convey to them so that they see something visually as well. And I know a lot of us do. So, and I don't remember where it originated, but, so I say, for a person without AD, or you can select psoriasis, whatever your, so, the immune system, the person without it, their immune system is here. And your immune system is very, very, very excited. So your immune system is here, right? So you take your other hand and then put it really high as here. And then what we're trying to do with the therapy, fill in the blank, is that we're trying to rebalance it. I don't know why I used to use the word normalize, then I realized rebalancing, I see more nods. So I think at least where I practice in West LA, they like the word rebalancing better. So we're trying to rebalance it. So we're trying to bring your very excited and inappropriately high inflammatory system down to where the normal area is. And I say sometimes we bring it perfectly, right? So we don't see any patches left. Other times, how do we know we didn't go as far enough? You probably still have a little bit left. So you see a little gap here. And I say, but with these therapies, we're not doing it like this. This is called immunosuppression. So I do this like hand thing so that they also visually try to see what I'm trying to get at. So I just want to add that one point.
Yeah, I think that's I think that the helping them understand because of their exposure in the media and their friends and everywhere, because maybe, and we may not be trusted individuals anymore as providers of medical care. There's a lot of skepticism, and it's so important to alleviate their concern of potential immunosuppression and scary side effects.
There's another challenging conversation common in dermatology clinics, and it relates to isotretinoin. In this episode's Dermalorian clinical clip, dermatologist Dr. Lisa Swanson offers some tips for talking to patients about this effective treatment.
When you're having the conversation about isotretinoin, it's important to get a feel for the room. How's everybody feeling about this? And a lot of times you can tell by their eye contact, their body language, and sometimes the questions they outright ask. But sometimes they're not even asking. Sometimes you can just tell that there is turmoil on the inside as soon as you mention isotretinoin. And so I start by asking, what have you heard? There's a lot of misinformation out there about isotretinoin. What have you heard? Or if they express concern about the treatment, what did you hear that scared you? Because there's so much misinformation out there. I'd love to hear what you heard to tell if it's true, if there's some semblance of truth to it, or if it's just complete gobbledygook. And so I always start from a place of let's sort through what you've heard and what maybe your misconceptions are. I make sure they know that isotretinoin is like nothing else. It works 100% of the time to clear up their acne. There is almost nothing that works in medicine 100% of the time. It's really quite special. And it's permanent the overwhelming majority of the time. That also is so special. We don't have any other acne treatments that provide some semblance of permanency. And so I make sure they know that. I make sure they know that it's a derivative of vitamin A, which often helps, and I talk at length about the reason that the iPledge program is in place, because I think the fact that there is the iPledge program and patients and parents have to sign and they have to come in every month, that creates kind of a big deal feel to the medication when it's not really that big of a deal. And so I explain that the medication causes horrendous birth defects if a woman takes it while pregnant. It doesn't do anything to fertility, to the patient's ability to have happy, healthy kids down the road, and it doesn't affect the offspring of male patients ever. And so I kind of sort that out. And I say the reason for the iPledge program is to help make sure that we don't see any pregnancies on this medication. It's designed to try to keep people safe. And so that's why you have to come in every month, and that's why you have to pee in a cup at every appointment if you're a female. And all of the rules that we have to follow, it's due to trying to protect a patient's best interest and to avoid pregnancy on the medication.
Thanks for joining us for this episode of the Dermalorian podcast from the Dermatology Education Foundation. Physician Resources produces the Dermalorian podcast on behalf of the DEF. We'll see you next time.